I'll be talking today about the current treatment strategies for pancreatic adenocarcinoma. No disclosures. This is the outline for my talk. I'll review two of the major randomized controlled trials for metastatic pancreatic adenocarcinoma that have emerged over the last 3 years. In particular, the use of FOLFIRINOX and then the use of Gemcitabine and nab-Paclitaxel, and then talk about, in particular, the application of these two chemotherapeutic regimens to patients with locally advanced pancreatic adenocarcinoma. So pancreatic adenocarcinoma, I think today at least, wins the award for the worst cancer being talked about. Seventh most common cancer, but the fourth leading cause of cancer mortality in the United States, largely due to the fact that 85% of patients present with metastatic disease. The all-stage 5-year overall survival, unfortunately, hasn't changed a lot over the last 25 or so years, being 5% 5-year overall survival in 1990 and only 6% at just last year. On the other hand, for patients with resectable disease, the 5-year survival is around 24%. So that's all very well and good nationally, but I think it's very important to think about the patients that we see and treat here in lower Alabama and the Florida Panhandle. And if you look at the Alabama statewide cancer registry numbers for 2002 to 2011, considering patients in Public Health Area 9, which is a lot of lower Alabama, and Mobile County being Public Health Area 11, in particular African American males in Area 9 actually have a 50% increased risk of pancreatic adenocarcinoma, and males regardless of race in Mobile County and in parts of Public Health Area 9 have a 20 to 50% increased mortality from pancreatic adenocarcinoma. And if you look at patients in the Florida Panhandle, it's the females, on the other hand, who seem to have an increased risk of pancreatic adenocarcinoma. So patients that we see with this particular deadly cancer, there's an ongoing problem and a need for further investigation. So chemotherapy for metastatic pancreatic cancer has long been really ineffective. 5-FU was the mainstay for many years, and it took until 1997 before Gemcitabine superseded it, showing maybe a month and a half improvement in median overall survival. And then we took a tiny step forward, perhaps, with the addition of Erlotinib to Gemcitabine, with, as you can see here, an increase in overall survival from 5.9 to 6.2 months, which correlates to mere weeks and a handful of weeks at that. And among and subsequent to all these trials, these two trials actually showed positive results. We have a number of trials that unfortunately didn't show any benefit at all, whether it's GEMS, cisplatin, or any sort of platinum agent, addition of targeted agents, or addition of more than one targeted agent, as you can see here with GEM, Erlotinib, and bevacizumab. And so I think the summary for chemotherapy for a long time for metastatic pancreatic cancer is that there was a series of unfortunate trials with really no improvement in survival. And so this is very much the bad beginning that I've been talking about. Part of that's starting to change now with the publication of two extremely important articles in the New England Journal of Medicine. The first of these, published in 2011, examining patients with metastatic pancreas cancer treated with either FOLFIRINOX or Gemcitabine. And so these are patients with an excellent performance status, either ECOG 1 or 0. They were randomized to either 6 months of FOLFIRINOX or 6 months of Gemcitabine. The FOLFIRINOX comprising not just 5-FU, but oxaliplatin and irinotecan, with the primary outcome measure being overall survival, with secondary outcome measures being progression-free survival, response, safety, and quality of life. And this is Kaplan-Meier curve of overall survival, and as you can see here, there's a clear space between those patients treated with FOLFIRINOX and those treated with gemcitabine, and it allowed around about just over 4-month improvement in overall survival for those patients treated with FOLFIRINOX over gemcitabine. And this is reflected also in progression-free survival, as you can see here, with the progression-free survival, median progression-free survival increasing, almost doubling from 3.3 to over almost 6.5 months, with a tripling of the objective response rate. However, this comes at a cost, as you can imagine, combining the 5FU with oxaliplatin and irinotecan, and there were more than 80% of patients in the trial had grade 3 or 4 toxicities, and these were primarily hematologic in the form of neutropenia, but also GI in the form of diarrhea, and as you can imagine, with the addition of oxaliplatin, a significant proportion of patients developing sensory neuropathy. So that leads us on to the emergence of gemcitabine and nab-Paclitaxel, or Abraxane is its brand name. So nab-Paclitaxel is a formulation of paclitaxel particles bound to albumin, and in preclinical studies it's been shown to have synergistic anti-tumor effects with gemcitabine, and also had improved the concentration of gemcitabine within the tumor. And in the earlier phase 1/2 trial published in JCO in 2011, it showed that at the maximum tolerated dose, the response rate was an amazing 48%, with a median survival of 12 months. So this was obviously fast-tracked into a phase 3 study, which was published just last year, a large multinational study of over 850 patients. Didn't necessarily need to have the highest performance status compared to the FOLFIRINOX trial, but previously untreated disease, and they were randomized to either nab-Paclitaxel plus gemcitabine or gemcitabine alone. And so as you can see for the overall survival curve, once again, a clear difference between the two treatment groups. The improvement in survival is not as marked compared to FOLFIRINOX. This goes from just under 7 months to 8.5 months, compared to 11 months with FOLFIRINOX, but still a statistically significant difference. And progression-free survival, once again, we see that there is a difference from 3.5 months to 5.5 months, so a 2-month improvement in median progression-free survival, and an objective response rate that goes well into the 20% range. So not quite as high as seen with the phase 1/2 trial. And nab-Paclitaxel with gemcitabine, so not as toxic as FOLFIRINOX. Serious adverse events, rather than over 80% with FOLFIRINOX, around 50% with the combination of gemcitabine and nab-Paclitaxel. And so the summary from this portion is that if the patient has a fantastic performance status, then they're more likely to tolerate the toxicity of FOLFIRINOX and derive the benefit, whereas if they're not quite the performance status, then the combination of gemcitabine and paclitaxel will allow them to tolerate it and see additional efficacy over gemcitabine alone. So moving on to locally advanced pancreatic cancer, there's been long-standing controversy in the surgical literature about what defines resectability for this particular disease. Tumours are defined as being resectable, obviously, when there's no evidence of distant metastasis and when there's no evidence of vascular invasion, in particular of the superior mesenteric vein, portal vein confluence, and no arterial invasion of either the celiac or its branches or of the SMA. Defining what's perhaps resectable as being somewhat harder to define, and these are termed the locally advanced tumours. those which are defined as borderline resectable, there is some involvement of the superior mesenteric vein, portal vein confluence, and potentially some involvement of the gastroduodenal artery close to the hepatic artery, or there's tumor abutment of the superior mesenteric artery of less than 180 degrees. Those which are defined as locally unresectable up front are those with a long segment of occlusion of the mesenteric portal vein confluence, or where there's greater than 180 degree encasement of the surrounding arterial structures. And so there's been a lot of interest in treating patients with locally advanced tumors, so not upfront resectable, with chemotherapy and or radiation therapy, and trying to downsize them to resectability. And using various chemotherapy regimens, this is the resultant resection rate after neoadjuvant treatment is of the range of about a quarter to a third, and this allows still a fairly poor complete resection rate of only 20 to 25%. And put this other comment in because it always seems to come up in various discussions about what sort of biliary stent should be placed for patients who have an adenocarcinoma in the head of the pancreas, about whether it's safe to put in a metallic stent, whether it impacts the surgery or not. And in general, we always ask for a metal biliary stent if we want to treat these patients in a neoadjuvant fashion, and no, it doesn't really affect the difficulty of the operation if the patient becomes resectable and is taken to the operating room. And the reason for that is that some of these patients who are treated with neoadjuvant regimens can be treated for anywhere from 3 months to over a year with various regimens, and the biliary stent, the metal biliary stents have not just a greater diameter, but a much better, much lower obstruction rate compared to the plastic biliary stents. So what about applying more modern chemotherapy regimens such as FOLFIRINOX or Gemcitabine nab-Paclitaxel to patients with locally advanced disease? So there are emerging studies, all retrospective, none randomized thus far, examining firstly FOLFIRINOX. And so the largest series is from Massachusetts General, published last year, actually all published last year. So small numbers, and you can see young patients, excellent performance status, and the objective response rate by RECIST criteria anywhere from a quarter to 2/3. The resection rate, I think, is very widely variable at this rate, as is the R0 resection rate. But as you can see, these are locally advanced tumors, and so R0 resection rate for a locally advanced tumor, like 44%, I would say, is actually very good. And intriguingly, and this is a number that I think we'll be watching very closely, is what percentage of patients who are treated in the neoadjuvant fashion go on to have a complete pathologic response. The catch, of course, with FOLFIRINOX, as I mentioned before, is not just in the metastatic setting, but in those patients with locally advanced tumors, that it still remains very toxic. And as you can see, only, I guess, I'm not sure what it means to be, of 22 patients, what to be the 2.5 patients who received the median cycle of full dose FOLFIRINOX. But as you can see, only 1 out of the 22 patients actually got at least 8 full dose cycles of FOLFIRINOX. So it remains toxic even in patients with excellent performance status without metastatic disease. And I guess important to note that most of these patients, almost all of them, did go on to receive radiation after getting their systemic chemotherapy. And so what about Gemcitabine and nab-Paclitaxel? Well, there are actually no even retrospective studies examining this issue quite yet, though I'm sure they're coming. Though there is a study that just got published from Virginia Mason in Seattle, looking at the combination of gemcitabine and docetaxel. And so these patients received 6 months of chemotherapy and 5FU-based radiation was added to that if there was still a question about resectability and the ability to obtain a complete resection. And as you can see here, it's actually a pretty large retrospective series, 64 patients. A lot of these patients had a defined radiologic response. About half the patients got resected, of which almost half had an R0 resection, and 10%, very similar to the FOLFIRINOX numbers, had a pathologic complete response. And an excellent 2-year disease-free survival, 85%. So I think there's a lot of room for optimism, not just in the metastatic setting, but for patients with locally advanced pancreatic cancers. And so this is one approach to decision-making for patients with pancreatic adenocarcinoma. I think patients who have metastatic disease, if they have excellent performance status, then FOLFIRINOX, I think, would be the agent of choice. If otherwise, Gemcitabine plus nab-Paclitaxel, and then failing that, if they're somewhat older and frailer, then Gemcitabine alone. For those patients with non-metastatic disease, then I think it's very important that these patients are reviewed in a multidisciplinary setting to decide whether they are upfront resectable, and if they are, then I think the standard of care is still to proceed to the operating room. However, if they're locally advanced, then, as I mentioned before, if they're very fit, then FOLFIRINOX or the Gemcitabine nab-Paclitaxel with evaluation of response to therapy at 3 and 6 months, and consideration of adjuvant and chemoradiation after that. And after completion of all therapy, then restaging. If they remain unresectable, then proceeding to second-line chemotherapy, but if they remain resectable, then proceeding to the OR. So with neoadjuvant therapy becoming more effective and therefore increasingly used, increasingly the question is going to be, well, how do we predict response in these patients? And there's some very interesting studies that are coming out, and clearly we'll see much more of these. I'll just highlight 2. One is a predictive biomarker, which is called HENT1, which is a transporter that is responsible for movement of chemotherapy agents both in and out of the cell. And this is a study just published earlier this year in the Journal of National Cancer Institute, showing that if you have higher levels of HENT1, then you have an improved survival compared to those patients who have lower levels. And the second is about the use of imaging to predict response to chemotherapy. Oftentimes, the pancreatic cancer is this hypoattenuating lesion that doesn't take up much contrast either in the arterial phase or the portal venous phase of the pancreatic protocol CT. And in other situations, the contrast enhancement of the tumor itself is very similar to that of the surrounding pancreas, both in the arterial phase and the portal venous phase. And so what some researchers did at MD Anderson is they mapped out the amount of contrast uptake during the CT with those patients who and then looked at the outcomes of patients according to how much enhancement of the tumor there was. And so in this very interesting study, then they went on to correlate the CT findings with the amount of gemcitabine in the tumor when the gemcitabine was given intraoperatively at the time of resection. And so essentially when they actually started to resect the specimen, this is intraoperatively, so there's, out here by the lamp, there's getting the patient to the OR, putting them to sleep, doing a laparoscopic stage to exclude metastatic disease. When the patient, when the surgeon actually finally made it to complete the dissection and starting to remove the tumor, that's when they started infusing gemcitabine. And once the specimen's out, then the pathologist actually took a bunch of core biopsies to determine the concentration of gemcitabine both within the normal pancreas and also within the tumor. And the first thing they found was that the concentrations of gemcitabine, when standardized according to time of resection, were very, very variable. You see from this waterfall plot, it's all over the shop. But they found that when they looked at the CT findings and the response to neoadjuvant therapy in a separate group of patients, that those patients who had higher contrast uptake were more likely to have a better response to neoadjuvant therapy compared to those patients who did not have very much contrast uptake. And this is shown here with the AUC is the area under the curve of the contrast uptake. So I think that the characterization of the physical properties as seen on CT scan, as well as the molecular properties such as presence of various biomarkers such as HEM1, are going to be very important for research in the patients in this population, as well as hopefully down the line selection of appropriate or more appropriate chemotherapy regimens. So in summary, I've talked a little bit about newer regimens for metastatic pancreatic cancer. FOLFIRINOX is the agent, is the regimen with the best efficacy at this point, with gemcitabine, nab-Paclitaxel not too far behind, but with a better tolerability. And for patients with locally advanced tumors, neoadjuvant regimens are now incorporating both FOLFIRINOX or gemcitabine, nab-Paclitaxel, and we'll continue to see better predictors of response both biochemically and from imaging. I'll end there and I'll have to take your questions.